starting with a diagnosis. So this is Rundle's curve, which holds good for any autoimmune disease. There's activity and severity. Activity denotes the function of inflammation, and severity denotes the functional or the cosmetic deficit. And the aim of any modality of treatment would be to blunt the peak of the activity curve and also to shorten the duration of the activity and the severity curves. So then, to know the activity, we have the widely accepted clinical activity score, which was published by Moritz et al. In 1989, which has 4 parameters. On the first visit, we assess pain, redness and swelling on a total score of 7, and a score of more than 3 by 7 would denote active disease. And at subsequent follow-up visits, we also assess the loss of function. So a total score of 10, wherein a score of more than 4 by 10 denotes active disease. Then we have the UGOGO severity score, which has 3 gradings: sight-threatening, moderate to severe and mild disease. So the disadvantages of UGOGO is that, for example, proptosis is there in all the 3 parameters, and it doesn't take into consideration the patient's perspective. It is more of an objective scoring. So to overcome this, Dolman et al. Published this VISA scoring, which is both subjective and objective, and it also denotes disease progression. It is more comprehensive, but in our clinical practice, it might be a little time consuming. So as I've emphasized that thyroid eye disease is a disease mainly of clinical diagnosis. However, imaging would be necessary mainly in euthyroid ophthalmopathy and also in unilateral asymmetric proptosis, and also in vision-threatening disease and before decompression. When you are suspecting any cerebral pathology such as CST or CCF, then brain imaging would be necessary. CT is the preferred modality, wherein fat serves as an excellent contrast material. MRI with diffusion-weighted imaging and T2 hyperintensity and prolonged T2 relaxation time helps in denoting the activity of the disease in previously treated disease, and also absolute diffusion coefficient mapping is also useful to denote the activity of the disease. Nowadays, OCT angiography in TED is gaining momentum. So now you know the activity and severity. So now it becomes pertinent to know when to treat the disease. So logically, sight-threatening disease would require urgent treatment. However, mild disease would require optional treatment. Then now that we know when to treat, how to treat becomes this one. So the 2021 UGOGO clinical practice guidelines has given clear-cut guidelines as how to manage the mild disease. In mild disease, it is mainly supportive treatment in the form of artificial tears and also selenium supplementation. Sorry, excuse me. So in moderate to severe disease and active Graves ophthalmopathy, the first line of treatment would be intravenous methylprednisolone and along with mycophenolate mofetil. The intravenous methylprednisolone can be started in the dose of 500 mg pulse therapy or 750 mg pulse therapy, and once the disease goes into inactive phase, then rehabilitative surgery as needed would be required. And the second line of treatment would be cyclosporin or azathioprine, orbital radiopathy, teprotumab, rituximab and tocilizumab. And in sight-threatening disease, usually you start with a high dose of intravenous methylprednisolone therapy, and finally, if it is not responsive, then urgent orbital decompression would be indicated. So now medical management. So these are the target therapies. Glucocorticoids usually act on both T cells and B cells. So oral versus intravenous, it is proven beyond doubt that intravenous is more efficient with less side effects. Kali's regimen has been widely practiced with a cumulative dose, safe dose of 4.5 to 8 grams, started in the pulse of 500 mg weekly for 6 weeks, followed by 250 mg weekly or 750 mg weekly, followed by 500 mg for 6 weeks, with the introduction of an immunomodulator at pulse 4. Then steroid sparing agents would be either cyclosporin, mycophenolate or azathioprine. So mycophenolate inhibits both T lymphocytes and B lymphocytes, given in a dose of 1 gram per day for 24 weeks, which has a minimal long-term benefit and it is well tolerated. Then cyclosporin alone or in combination with glucocorticoid therapy, given in a dose of 5 mg per kg body weight. It inhibits calcineurin and also prevents the secretion of IL-2 by CD4 plus lymphocytes. And azathioprine, which is usually practiced given by the oculoplasty surgeons alone, which inhibits DNA synthesis, which has a good adverse effect profile, and also it decreases morbidity, reduces the clinical activity score, and also improves diplopia. Then orbital radiation therapy, it is the most controversial I feel. It reduces the secretion of pro-inflammatory cytokines from activated lymphocytes. So this was one patient who presented like this, who was given pulse methylprednisolone therapy along with mycophenolate mofetil. There was remission, but he relapsed later. He was not ready for any surgical treatment. So orbital radiotherapy was given, and this was the final outcome. And coming to the surgical management, we all have been taught that orbit followed by extraocular muscles and eyelid, but it is now proven that combined orbital decompression and aesthetic eyelid surgeries has better patient satisfaction and reduced number of surgeries. And for eyelid surgery, it's LPS recession in the quiescent phase, whereas in the active phase, non-surgical modalities in the form of botulinum toxin, triamcinolone, and hyaluronic acid fillers can be used. This is one of the patients wherein combined orbital decompression and aesthetic eyelid surgery was done in the same setting. Targeted therapy includes teprotumab, which is readily available in the West, not available in this subcontinent, rituximab, tocilizumab, and infliximab. Rituximab is against CD20, 2 infusions of 1 gram 2 weeks apart. So this was one such patient who had all the high-risk factors, secondary glaucoma, active vision-threatening disease with DAWN, who was given IVMP pulse therapy, which was supplemented with rituximab, and this is the final outcome. Teprotumab, which is gaining momentum, it acts against IGF-1 receptor. It reduces hyaluron production and cytokine stimulation. The quality of life was significantly improved with significant improvement in diplopia, and long-term benefits even after the final infusion was the most advantageous this one, and the others are tocilizumab, adalimumab, and infliximab. So in conclusion, thyroid eye disease is a progressive debilitating autoimmune disease with a very limited window period to treat, which requires meticulous examination because clinical diagnosis is the cornerstone in the diagnosis. A multidisciplinary team approach is required, and novel targeted therapies are the way forward. Thank you very much for your kind patience.
Just explain few points regarding euthyroid ophthalmopathy is one of the burning issue right now. Most of the time there may be started with a hypo, U and hyper, and that time the general physician or even the endocrinologist also misguide the people because it's not possible to all do these drugs. There may be some issues if there is some complication because there is systemic complication is very high. So we need some support from the other stuff.
Yes, sir.
And there is a practically, theoretically is very easy, but practically there is some issues. How you will tackle all those points? Suppose euthyroid normal, TTTS normal, even anti-TPO are normal, then in such cases clinically is clean cut case of a thyroid ophthalmopathy.
Yes, sir.
What
So
will be your approach?
usually euthyroid ophthalmopathy, we all were thought that it was more of a clinical diagnosis, but now with the present studies, it is proven that only TSH receptor antibody being positive or proptosis alone doesn't necessitate the diagnosis. We require imaging to support the diagnosis, especially in the form of extraocular muscle involvement or orbital apex crowding and all. So supplemental diagnostic modalities in the form of visual fields and to how much extent the optic nerve is also affected we'll have to take a holistic approach to treat such diseases. And also there is a lot of controversy among the endocrinologists itself whether to initiate thyroid medications in case of euthyroid ophthalmopathy. Because many a times, as an oculoplasty surgeon, we see that the burden of disease is so much, the quality of life is so much compromised, and the patient is so much in trouble. But then, for them, they just rely only upon the free T3, T4, and the TSH levels. Yes. If the TSH levels are normal, they don't even budge even after personal communication with them. Yeah. But then, I don't have much data, but in my practice, when thyroid medication was started, even in euthyroid ophthalmopathy, there was better improvement in symptoms, and whatever treatment we initiated, like oral corticosteroid, the effect was better when it was supplemented with thyroid control also.
Thank you.
Thank you.
In my practice, generally, if clinically is a tau, thyroid
Yes, sir.
associated ophthalmopathy. So I straight away advise anti-TPO and thyroid antiglobulin
Yes,
first.
sir.
Because that if the TSS or free TTT4 is within the range, there is a patients are generally reluctant. They will not go for that is aggressive one, and perimetry in the first one.
Yes.
So that initially in our hand, initially first all I this is it to motivate people.
Yes,
That's
sir.
a one thing we have to, because more than 60% of they are basically 1 or 2 years senior. To convince them it is very difficult in higher post also in some hospital.
Definitely.
So very very big issues. Yes.
Yes.
Practically, are we having all those rituximab and all?
Yes, sir. Rituximab is available, and immunologists are quite keen on, on administering rituximab.
So you take help of other
Yes, sir.
specialists?
Definitely. With in consultation with the immunologist, and the immunologist will only follow their other biochemical parameters so that the adverse effect profile is also in check.
Only few, the serum creatinine and then liver function test we can also, because
Yes, sir.
especially I am personally using the azathioprine up to that in some uveitis patients. With this, if the all parameters are normal, then we can start safely, because if you send to them you can discuss, but if you are sending to some senior one, technically it will be little difficult to convince them. So generally I send to some senior with a note, and there is just technically that I take a consent from that proper authority, like, and then start.
Even I start myself on Azuran, and I check the liver function test and CBC periodically every 4 to 6 weeks. And if there's any, even the slightest discrepancy, take the immunologist helps.
Even they are also doing the same thing. Whatever we can do, they are also doing the same thing. So that is, we should maintain the proper protocol, and for the CPA point of view for protection, we can send to someone what one consent. That's enough.
Yes. Sure. Thank you.
Requesting Dr. Raman Mittal to present his topic, droopy eyelids, what all to look in for.
Good evening, ladies and gentlemen. I see that most of the people are enjoying outside, but whosoever is inside, let's dwell upon the droopy eyelids, which is ptosis. And we all know about the normal ptosis which we have, congenital and aponeurotic ones. But in this presentation, my interest would be to discuss with you all what all other factors and what all other things which you need to see in cases where the patient presents you as ptosis, but there are so many other things which can mimic ptosis. So by ptosis or by droopy lids, it is drooping of either one or both the eyelids, which could be present congenital or acquired. These are the workup schedule which we all know, that we need to work up on fissure height, margin reflex distance, crease distance, LPS section and whatnot. And the surgical procedures also, for depending upon what procedure is done, depending upon what findings we have, we decide upon the procedure. But here, apart from congenital ptosis, which is normal, we see poor LPS section, moderate to severe ptosis, you go in for sling surgeries. Here, if the ptosis LPS section is good, you do LPS resections. Acquired ptosis, senile aponeurotic is still the commonest, which you face like this. It could be an aged gentleman. This was around 90 plus, and within 2 weeks he is doing so well. So all his forehead lifting and this thing has gone. So now I will discuss this. All we know. So I have just brushed it through. Now what we want to know is the variants or the changes which we have in the droopy eyelids. Like a ptosis patient may present with double elevator palsy. So once you lift the lid and see the globe, you may see that there is hypotropia along with the ptosis, and there is superior movement restriction. So in these type of cases where there is a hypotropia, you first need to treat the hypotropia and then you treat the ptosis. Otherwise, the patient will not be happy and your thing would remain undercorrected. Marcus gun phenomena is another important association which we may have with ptosis, and sometimes I myself am not convinced about disinserting the LPS of both the lids and doing sling surgeries just in case to correct the Marcus gun. My take is once you correct the ptosis, Marcus gun anyway reduces quite a bit. So if you counsel the patient's attendants well, that it will be reduced if not completely gone, but we are not touching the normal eye, they are convinced, and you should take care of that. This I have kept it as a variant of ptosis because not only there is a drooping lids, but there is decrease in the horizontal fissure width as well. So if you have a high suspicious index, you should measure those horizontal fissure as well, and you should correct them along with or before doing the vertical correction to give a good result as we see in this slide. Sometimes we have a normal ptosis, but here in this picture what we see is that there is an inferior scleral show. So this inferior scleral show was well documented and was well discussed with the patient beforehand, because after I corrected the ptosis, they were saying that this is overcorrected, but actually this is not a case of overcorrected. If you see the upper margin, the upper eyelid margin, they are well in place, but because of the inferior scleral show, it is looking like it is overcorrected. So I had to, most of the times it gets corrected automatically, but in this case I had to correct the lower eyelid as well, and after the second stage surgery she was perfectly fine. We also know about the variants of ptosis in cases of myasthenia gravis and CPEO, which is chronic progressive external ophthalmoplegia. Sometimes it could be a neurogenic third nerve palsy which present to you as ptosis, or droopy eyelid, could be traumatic or mechanical. I'll be discussing few cases. Myasthenia, we all know there is variability, there is generalized weakness of either ocular muscles or other body muscles. Sometimes they are only 15% of they are purely ocular, others are general myasthenia gravis. There is fluctuation of the drooping, there is worsening of ocular symptoms as the patient is doing reading, watching television or driving and all. So worsening of jaw muscle on weakness and all that stuff. So worsening factor is there on exertion or in getting fatigue. Here looks like a simple case of ptosis, but actually she had ocular myasthenia gravis. So in ocular myasthenia gravis, the patient may present to you with only ptosis or may have even diplopia or may have even inappropriate closure of the lids. So there could be an orbicularis weakness as well. Of course, we know that anti-acetylcholine receptor antibodies, Tensilon tests, electromyography, and ICE test, which is very important, very easy to do in the office, is there. So management, we can go with medical management or ptosis crutches if we know. Once the patient is not improving with all this, sometimes you actually need to resort for surgical management also. In diplopias, you can do patching and prisms and all that stuff. In CPO, where it is not improving with medical management, there is restriction of the movements. You can give crutch glasses to manage this patient, and then you can lift the eyelids. But sometimes I have started doing surgeries after doing a proper counseling with under correction, so that just to spare the pupil so the patient can see. Third nerve palsies, again we have to lift the lid, see for the movements, look in for the history. With conservative management they get well. Like in this lady, she was absolutely corrected. So I'm just keeping this as variants because sometimes patients present to you with drooping of lids and we jump into the conclusion because the referring doctor would have also mentioned ptosis and you jump into the conclusion of doing ptosis corrections, but it's not the case. And this is a very interesting case because this presented as an acute onset or a sudden onset drooping, but there was a myocysticercosis on ultrasonography. So with the management, medically of course we know, she corrected well. And similar was this young lady who had inflammatory signs as well as severe ptosis, but she was absolutely corrected after 1 week of management. So we have to keep all those things in mind. That's what I'm trying to suggest. This patient who was referred to me as congenital ptosis actually also had enophthalmos with poor movements in all the gazes. So I got her investigations done. Her scan showed that she had very atrophied muscles. So I was not dealing with a simple case of congenital ptosis, but it was a case where the muscles were actually not developed. And you see in the picture below that she is not having movements. So first I counseled the parents well and then planned to do an enophthalmos correction, and then after doing the enophthalmos correction we did the ptosis correction. I think we have some speakers not there, so we can continue. Thank you.
Talk one. Sometimes we are talking about the myasthenia in CPO. So I am also doing now the surgeries. And what type of surgery you will prefer?
Okay, that's a good question. If there is absolutely zero LPS section, Okay, because the movements are not there, difficult to calculate the LPS section. If there's absolutely no flick in the LPS, then I sometimes resort to doing sling surgeries. Why? Because sling surgeries, you have a better control on what lift you want. But before that, I would check properly the orbicularis section. If the orbicularis section is good, only then I would go in for a ptosis correction surgery. If the orbicularis section is also weak, I will not go in for a ptosis correction surgery. If I see a flick of LPS, but there is also movements are there, it's not total frozen movements, then I would go in for an LPS. So I have done LPS as well as sling surgeries with good results in both.
I have a question, sir. I think sling surgery will be better because if there is exposure post-operative and not corneal, it is very easy to remove it and reversible.
Yes.
Agreed.
Ptosis we can achieve.
The
And
problem
the LPS
is
will be, sir, again you have to open and
generally, if you treat them well, if you counsel them well, and you keep them under your scrutiny, they'll land up into complications, I agree, but they come up well also. In sling surgery, another problem which I find it, because it cuts through the tissues and the muscles are already weak, sling ultimately gets loosened up. So that is another issue, you know. And nocturnal leg of ophthalmos is much more severe in cases of sling surgeries, and these guys already have poor bells. So that's why that's a gray zone. We all need to come to a conclusion. Yeah, Dr. Neelam, yes. Try to lift.
But still, you can. There's a direct mechanical lift. Definitely. Yes. Not only I will explain that.
Yeah. When I say sling, I mean silicone sling. I am not doing facial atas anyway. So, but
Yeah.
yes, your point is well taken and very well explained.
Yes. Always. That's why I'm asking his question. Yeah. So always silicone. I always prefer. If you are doing the fasalata, in fasalata for a normal people is okay. There is a adhesion. There is a normal tissue, more reaction. There is a adhesion inside. So there may be a more injury on that muscle. So there may be a more leg of thermus, etc. also. But in silicone, there is a elasticity, good quality elasticity. One advantage is a mechanical plus elastic mechanism will work. And I don't have any such courage to go for a almost full correction, or I am just
Absolutely not.
slowly, very minimal, just up to that, just pupil, just pupil.
Quite
Too
undercorrected.
Too
So
much
just
undercorrection for
bear
sure.
this pupil and they do well. So in this case, I did inophthalmos correction first, and after doing the inophthalmos correction, I placed an orbital implant. Okay.
Please, madam, please tell. What your question?
How did I do the
Okay,
orbital?
okay, madam.
So in this, I placed orbital sheets below the globe. So that lifted the globe from behind. So that corrected the inophthalmos in this case. I already explained the patient, she already had a frozen globe. So movements won't be there. So once the inophthalmos was corrected, there was only a slight correction in the ptosis. In this case, it was not a very good correction, which we would see in the traumatic inophthalmos cases. So this was her picture after inophthalmos correction. So once inophthalmos was corrected, then I did ptosis correction. Why I did inophthalmos correction was the reason, because if I would have gone for ptosis primarily, one, I would have to do overcorrection because there was an underlying inoph. Secondly, she is a girl and she would become marriageable age then, and inophthalmos would always keep on bothering her because the eye would be looking like sometimes sunken than the other eye. So in this case, the thing was only cosmetic, and to achieve a proper cosmetic, and if I do a ptosis first and then do an inophthalmos, again it will change my variables. So inophthalmos correction was the first one which was decided by doing orbital implants. I did a double sheet, if I am not wrong, if I am remembering, 1.5 millimeter thick 4x sheet that was placed in the orbital floor, 2 slices, and then I did 4x. So in this, the mechanical ptosis because of the capillary hemangioma, again the patient was referred as congenital ptosis, but on seeing the patient, on everting the lid as drawn in this diagram, patient actually had an underlying capillary hemangioma, and once you conservatively manage the child, it got better, and you see that the ptosis was corrected. In this lady, again, the patient came to us as a case of acquired ptosis, a middle-aged female. On first look, she looks like either a case of ptosis or a case of retraction of the other eye, because we see that the margin is there on the upper or the superior limbus. But on everting the lid, once you open the lid and see, there is a salmon patch-like appearance underneath. And you see that was to be corrected. So she got fine after doing that correction. And similar, this case, the child never gave a history of any trauma and all, but on everting the lid or opening the lid, you see there's a huge lesion below the lid, which is actually adhering to the undersurface and causing ptosis. So it was a case of pseudotosis, and once I excised that lesion, the patient's ptosis got automatically corrected. I did not do any ptosis correction for this child. Of course, we know that microcorneas patients sometimes present with ptosis, either unilateral or bilateral. We need to tell them about their condition, that the underlying eye is at problem, and in these type of cases, you need to do a ptosis correction, having looked that the cornea would be smaller again. Thyroid orbitopathy has been discussed, but sometimes the patient may present to us with ptosis with full movements and all. So here, after doing all the medical conservative managements, sometimes we need to do surgical corrections, either doing LPS recession as the previous speaker explained, or even LPS elevations. So here it was a case of retraction who was not managed, who could not be managed conservatively. So I did LPS recession for the patient with a good cosmetic correction later. Thank you very much. So all these things are like we can have asymmetry of the lid height, and ptosis is not the only diagnosis, but there are so many other things which we should keep in mind.
Raman, in case of a capillary hemangioma, what is your
Propranolol, 2 milligram per kg body weight in divided doses.
Yes, that is the very effective propranolol. And are you start from your own, or you are taking some help from others?
I actually my brother is a pediatrician, so
it's easier for you.
It's not easy for me because convincing your family members are difficult.
Yes.
So I took help of a pediatric cardiologist. I took help of pediatricians, but they are very negative about it.
Yes.
They don't want to take the onus on them. So you have to explain to the parents that nothing happens to them. You can start with the minimal dose. There'll be 10 to 20% of the patients or the parents, I would say, who are not convinced, because they would go and Googleize, and Google would tell you that there's so many things. But in a span of my experience of more than, I guess now 12 years that I'm doing propranolol, and even I have given it for few months old children, nobody has any problem. And disclaimer is that I myself use propranolol for the last 3 years for some tachycardia condition, and my daughter is also using. So I have seen personally that apart from that it reduces the heartbeat, bradycardia is of course, nothing else happens. And of course, there's a withdrawal effect. So once you have to finish off, or you can say stop the treatment, don't stop it abruptly. Yes. Just do it tapering. So that is important. I have realized myself over the period of time that once I do tapering, then the patients behave well. Otherwise, they may have some palpitation and tachycardia complaints. In kids, it's not so much, but yes, it is possible. But no complication or side effects.
Propranolol even ointment also now, I think some kind of glaucoma people are using some ointments. We can use it.
Timolol is something which we give for local, like in conjunctival capillary hemangiomas, we give timolol gel types. I have not come across propranolol ointment. Do we have?
No, that timolol.
Timolol, yes. Timolol, yes. Beta blockers.
Beta blockers. And just I always advise my children, instead of, if you are sending to the pediatric cardiologist, generally very few are tuned with the pediatric cardiology, and most of the time they are echo are done by the diploma holders, and the DM is mainly looking at some high halo. That's the reality. That's why I always advise straight to echocardiography and ECG to compare the heart rate. Ask the sister to see the pulse. If the pulse is more than 76 or 80, you are very safe.
Generally, it is because the kids anyway have tachy.
Yes, techie. Most of the time
That's
is
a normal
lucky.
thing for the kids to have. They are
Tachy.
anyway having a higher pulse rate.
Most of the time there is a 90 or 80
And
or
to be on the
whatever.
medical legal safe, as you say,
Yes, yeah.
I definitely write in consultation with pediatrician,
pediatrician.
though I may not convince them hard to go
Yes.
to a pediatrician, but I write it so that I can budge on it, that I have told them, they have forgotten it.
Or
So-
sometimes I started myself and asked them to consult local pediatrician after 15 days.
Yeah, yeah.
Safeguard.
So that's the way. Well, we should be keeping ourselves medical legally safe. We have to write it. I mean, institutes where in the house, how convinced they are to start propranolol for younger
No,
kids?
they are.
Yeah. Most of the time, what I have seen is they will tell us telephonically, yes, you can go ahead. They will not write. In my practice, I have seen most of the times they will say nothing will happen, go and get it started, but they will not write it, okay, yes, it is safe to start. That's what I have come across, at least in private practice.
But in private, I am also right now doing private
Yeah.
practice. I am just telling particularly doctor with that institute, with the special note, need that one, and telephonically convince them. And this is technically is very difficult if there's something happen. And ask the parents to purchase a pulse oximeter at least at the home. They can check every day. I ask to every day, and every 7 days you just send me the reports of the pulse.
That's a good idea, I guess. That can be done easily.
Is a good practice in private practice. Okay, madam, please.
Yes. Yes. I've done because, see, if you see that the LPS section is poor, you decide that you're going to do sling. So it's a fixed thing that you are going to do it. So now when you are correcting the hypotropia, once the patient is under general anesthesia, it's the only purpose that you're bringing the globe to the centric position. The LPS section is not going to change. The excursion of the lid, the previous, before surgery, after surgery, doesn't matter if you're doing sling surgery. It is what you leave on the table. So if you have that type of condition, you can easily do it. I have done in few cases. Anyway, in sling surgeries, they tend towards undercorrection, or even in severe congenital surgeries, ptosis surgeries, undercorrection is the rule. So you have to overcorrect. It is a very well documented rule that congenital ptosis with poor LPS section, they are going to fall into undercorrection category. So overcorrection is the rule. You have to overcorrect, and if you have it so soon, you'll devise the surgery.
At one point, please sit. One point with. So suppose you overcorrect it, and in over 6 months again undercorrect, because that person is, if there is a unilateral, they are not using the one side. So before surgery, you just tease him or her to elevate the eyebrow, because we are implanting something here only. You have to lift up your by its own. You just explain it, then it is very successful. Anyway, whatever, after 3 to 4 months there is a drooping. That's why the rule of the thumb is always sling. In case of unilateral, you have to overcorrect it. You should be mentally ready to face all kind of corneal exposure on that particular 3 month only. That's why that penthizol or whatever lubricant is generally for 6 months at least minimum. Then it's generally droops.
Any questions further? Thank you so very much. Nice to have such an attentive audience.
Ma'am, you want to speak something, then we can discuss the other topics also. We can discuss few other. No, you are already. You can just. No, for other we can cover because the injustice for the audience. So we can just cover a few points if some have some questions. So. Yeah, no, we can. If you want to cover, you can cover a few more points also. Other topic. Interactive, then discuss between. We can discuss if you have any questions in between also.
Yes, yes, yes. Yeah. You can stop me in between. No issues. Good afternoon, everyone. So, I'll be sharing with you my experience on pediatric orbital lesions. So, we should remember that pediatric orbital lesions or tumors, they differ from adult types and also according to the age of presentation. Cystic lesions are the most common, especially in the periorbital area in children. Second most common are the vascular lesions, mostly infantile hemangioma, which we also call capillary hemangioma, lymphatic malformations, and rhabdomyosarcoma is the most common malignant orbital tumor. So, if a baby is born with proptosis, what are the, though it's a very uncommon situation, but you should remember some differentials when a baby is born with proptosis. This is something we commonly see that there is some bulge in the inferior lid, and if you retract the lids, you will see the globe is small. So, we know that we are dealing with microphthalmos with cyst. And the treatment in these patients, you have to wait for some time, but I prefer removal of the cyst with eyeball if there is no vision potential early in life, say around 2 years of age, because once the orbital deformity sets in, it becomes very difficult to place an implant and it can migrate inferiorly because the orbital cavity can get deformed if you suppose call the patient at say 3 to 4 years of age. Plus, pediatric assessment is also very important in these patients. So, if no vision potential, try to intervene early so that the orbital cavity is not deformed. So, this is just to show the picture of the cyst which is opened up, and you can see the open embryonic fissure. The arrow is showing that. Another very important entity we should keep in mind in a baby born with proptosis is the meningocele. So, meningocele, we all know what it is, but here I just want to highlight, if you see the above picture, this can be confused with amniocele. This was basically a baby with a large defect in the cribriform plate. This was anterior variety of meningocele, and so we have to be very careful when we are examining such patients with the congenital malformation. They can be defect in the roof or medial orbit or cribriform plate. The posterior variety is little less common than the anterior one, and the posterior variety you will see patient will give history of proptosis since birth, which is progressing in the proptosis which is progressing with time. So, the posterior one generally is seen along the lateral orbital wall, as you can see here in the picture. A very rare. That is the anterior meningocele. That's what I'm trying to say. This patient had a large defect in the cribriform plate. You are absolutely right. If you see the swelling over here, the swelling is predominantly anterior to the medial canthus. It is not really shifting the medial canthus. This is something which really tells us that it is not in the lacrimal sac area. Plus, if you see there is little bit of hypertellurism, telecanthus kind of thing is there. And I don't remember clearly, but in these patients, transmitted pulsations is something which you should always check. So please don't just put in the needle just to aspirate thinking that this is amniocele and try to do all that. So basic examination here I want to highlight is transmitted CSF pulsations. One should always check and keep anterior meningocele in mind. That means this was a very small baby. I don't remember that much, epiphora and all, no. But this was the kind, this was like few days old baby. Yeah, 2 months.
Why because we may encounter all those before 2 months.
And this we have published also, this particular image presenting as, amniocele. So though very rare, but yes, we have to keep these things in mind. And this baby, the lower picture, if you see clear cut, you can see that there is a defect. So these patients are to be referred to neurosurgeons. Orbital teratoma is a very rare tumor. A baby who presents with a severe proptosis which is progressing, say, over weeks' time, please think about teratoma, because that is one thing which I have seen, though very few cases over my almost 2 decades experience. But this is what you see on imaging, that there is a heterogeneous lesion with large cystic cavities, and sometimes you can even see tooth within it. So if possible, try to save the globe, otherwise we have to take out the whole thing. So this is again a very rare, interesting case. This baby again born, as you can see, neonate, with a lesion like this and a gross lateral dystropia of the eyeball. So this patient had 2 dermoid cysts in the orbit which were removed. And this was the largest series of 280 cases which we had published, in which I have published this picture also of some rare cases. And this again a very small baby, neonate, as you can see, with a massive proptosis. Imaging showed large cystic areas, and then it was aspirated, which helped in subsiding the proptosis, but the eye was lost. This is a very rare case which we had published. This was a case of congenital melanocytoma, and which has typical, all around the skin, you can see melanosis is there. There is pigmentation all around the lid. Plus, systemically, there are nevi in these patients, and in the center, it's not actually bindi, it's a neva sitting right there. So these tumors, they can undergo malignant transformation. So exenteration was done, and you can see the gross specimen, the structures you cannot delineate at all, and it is all filled with the melanocytoma tumors. Again, this was published, a very, very rare presentation. Only one case I have seen till now. Then glial heterotopia, again a very rare presentation, but yes, I must say any patient giving history of proptosis, say in infancy, you should always ask for the old pictures. Maybe there was some proptosis at birth itself. That gives us a lot of clue. So this patient, if you see, this was a glial heterotopia. Again, as the name suggests, the glial tissue was displaced from the brain without any communication with the brain. So the orbital cavity was, nicely formed. There was no communication at all. And if you see here, the hypodense area was basically CSF. On histopathology, choroid plexus was seen, and plus the glial tissue was also seen. So again, this is a very rare case. So in infants, in very small children, generally it's the rare thing we come across in the orbit. This is again a very rare case which we had published of a low-grade myofibroblastic sarcoma in an infant. If you see the first picture, figure A, that was the initial presentation. So this patient was debulking was done for this patient, but again there was recurrence, and then followed that this patient was referred to oncologist because it was really very extensive intraoperatively, though it is not very much visible here, but it was all extensively involving this particular part of the face. So because of the recurrence, it was sent, and then this patient was started on pazopanib, which is anti-angiogenic targeted therapy for almost a year, and 2 years follow-up, it is still stable. So now coming to lesions in infancy, 2 years age group. So we all know it's the capillary hemangioma in the early life, and in the later life it is the lymphatic malformation, which is we commonly see. For the infantile hemangioma, the standard of care is oral propranolol. And rarely we do come across LCH, and which basically in the orbit you see as lytic lesion, generally involving the frontal bone or the lateral part of the bone with some soft tissue component. This can be unifocal, multifocal, unisystem, multisystem, and depending on that, you have to treat these patients with oral or intralesional steroids. Orbital retinoblastoma, we all know they can present with orbital extension, and the treatment is to start neoadjuvant chemotherapy. Then coming to metastatic neuroblastoma, again we see these patients. Unfortunately, they present with bilateral proptosis and ecchymosis, also known as raccoon eyes. And in around 20% patient with this neuroblastoma, there is orbital involvement. And in around 3 to 4% patient, this is the initial sign as we see over here. And typically, you will see, you know, triradiate kind of lesion, which is there in the lateral part of the orbit, which has the component in the orbit, the temporalis fossa, even the intracranial. And they respond very well to chemotherapy otherwise. And you can see the pre and post chemotherapy picture over here. Again, this is a very rare case, an infant who presented with very aggressive looking, you know, eye, and intraoperatively it bled a lot. And so this patient had hemangiopericytoma, which otherwise we see generally in adults in 5th decade of life, and it is said that in children it is more aggressive, it has more mitotic figures and more necrosis. And this was the first case, and which was basically treated by chemotherapy, and you can see the complete resolution of the lesion. Only biopsy was done in this patient, followed by referral to medical oncologist. So with medical oncologist, you should really have very good, you know, otherwise, you know, rapport with them, so that you can directly communicate for these patients. They need very early intervention, immediate chemotherapy within 2-3 weeks, and we can't wait for we can't lose the eye, you know, because sometimes they are very rapidly progressing. Then coming to some lesions in the childhood, again we all know it's the veno-lymphatic malformation, and amongst the malignant it is the rhabdomyosarcoma. And the standard of care now has shifted from surgical debulking to intralesional sclerotherapy, and we prefer giving bleomycin. And you can see this multiple session of bleo injection in this particular child. And sometimes we see, you know, fluid levels, which are almost, you know, diagnostic when they are present along with the cystic, you know, lesion in the orbit. And you can see macro as well as microcyst in this particular imaging. So this is just, no, along with the lignocaine, yeah.
Not even 5 fluorouracil?
No.
I gave in a couple of cases 5 fluorouracil.
You can try, but as a routine we are not. With bleomycin. So actually we give little oral steroid for a short period, because sometimes bleomycin can lead to post-op inflammation. So I think that is a good option, that you mix it, but routinely we are not doing. But routinely we are adding for a very short period course of low dose oral steroid.
Are you using bleomycin intralesional, perilesional, or what is it?
Intralesional,
All
after aspirating.
intralesional.
Yeah, after aspirating.
Yes. So, are you prefer to ultrasound guided aspiration or
Yes, we do.
Yes,
We
that's
do.
a important very. So, my protocol generally I take a help from the radiologist instead of myself, that I just put in a where that ultrasound machine is available. So for on behalf of me, he is doing that thing, and I ask him to beat that one, and always that is under GA, so it will be easier for the. Basically, in the OT, you can bring those machines, ultrasound machines, as well as preferably Doppler, but it is very difficult to convince the authority to.
Actually, we have available ultrasound. We do ourselves. We do ourselves, and we inject and do ourselves. And this is just to show the chocolate cyst, though we don't really operate that frequently now, these patients. This is, you can see how the chocolate cyst looks like. So neurofibromatosis is another area we all know, 1 and 2. The 1 usually present with orbitotemporal lesion, and this was interesting case with almost all features of neurofibromatosis 2. As you can see, huge orbital schwannoma over there, which was cystic schwannoma. Along with that, you can see cutaneous neurofibroma. Lower picture, you can see on your left side, it is the acoustic schwannoma and the meningioma. Dermoid cyst in young children, generally you see periorbital. The orbital one generally affects the young adults, and the treatment is to remove it. And on CT, generally most of the time it is diagnostic because we see the fat Hounsfield value. So this is just to show the external angular dermoid and deep orbital dermoid in a girl which was removed. Hydatid cyst, a very rare parasitic infestation cases we see, and in this generally seen in young adults, this girl you can see it's like 2 eyeballs in the orbit. So because it's a very hypoechoic, almost no echoes on ultrasound you see, very few sand and all you will see. Plus this double wall sign, which is if it's there, it's almost diagnostic of hydatid cyst. So this is just a short video of how the hydatid cyst in this particular girl was taken out by the conjunctival approach. So here I had already aspirated the fluid and I have given nick in the pericyst. So this is nick which I am giving in the pericyst so that easily I can take out the ectocyst. Is this absolutely white looking thing which looks like egg white. So with the help of cryoprobe, I am extracting the ectocyst along with the endocyst, and generally the plane is loose between the pericyst and the ectocyst, but still you have to be ready with second instrument in hand, maybe a spatula or something, which will help you in really taking it out. So it was completely taken out in this particular case, and this was how it appeared. And after that, it's important that you flush because some or the other spillage is there. It's very difficult to avoid this spillage in these patients. Sorry. So this is the gross picture and pre and post surgery. Glioma again is very important thing which we see in young children. It's important that we differentiate non-neurofibromatosis glioma from the neurofibromatosis one. The non-neurofibromatosis gliomas, they are usually globular, they have poor prognosis, they progresses fast. Generally you have to, the eye is blind and we have to take help of neurosurgeons. The ones with neurofibromatosis, generally they progress less and visual prognosis is good, so keep them under observation. Rhabdomyosarcoma, it's the commonest malignant tumor. Generally our role is to do a biopsy, don't unnecessarily try to take out the tumor, damaging the structure. Best is just to take out a small piece and it just melts away with the chemotherapy. So this is one thing we should remember, that leave them these cases to the oncologist. Leukemia, granulocytic sarcoma, or any child presenting with proptosis with the mass lesion, routinely in our setup we get peripheral blood smear done, and most of the time we are able to avoid unnecessary biopsy under GA. So these all patients, they are sent to the oncologist. This is just one picture of metastatic orbital tumor, Ewing sarcoma, metastasized from the pelvis. And again, the chemotherapy has a role. Thank you so much.
Madam, in case of suppose there is a glioma, big glioma, Gamana of course one of the option. Radiation is one of the option, but
Yeah,
it is not possible in all patients. So that neurosurgeon help us a lot. Are you allowed neurosurgeon to remove the tumor, or you yourself, your team remove that tumor?
They, we refer to neurosurgery and they call us for the assistance.
Yes,
So when they are doing the orbital part, we remove that part and rest of the thing, because if suppose it is going till the optic canal, it's always better to have
Yes, it's very
tumor
easy,
free this thing. So they ask us to come and we go.
Generally earlier I did when I was in the only eye institute. Generally in poor patient is very difficult to go for and big lateral orbitomy, that is a lots of issues. Nowadays what neurosurgeon can lift it up the temporal lobe with the retractor, then you can go ahead like a open sky vitrectomy kind of thing in PK. You can do all thing and then they can again fit it all. It's very
Because
easy.
for orbital surgeon, invariably I feel that you will leave some amount of
Lots,
glioma tissue, and then
yes.
we are basically not doing justice
Yes,
for the
ma'am.
patient.
And
We need to have neurosurgeons.
and just for the audience, other, if you just send to that neurosurgeon, there's a habit is they are not removing any tumor in toto. Most of the time they are doing, because they are doing a very delicate structure. They are using bipolar and doing a piecemeal technique.
Yeah,
So
that's
generally I
right.
don't allow this thing. So I just ask them to please open it and just hand over to me.
See, the thing is that what we are preventing by removing the tumor, that we are preventing the, yeah, that is right, but we are
Recurrence?
also preventing the further extension in the chiasma, intracranial, and all that. Most of the patients, some amount is left, and where grossly it is left, then probably we have to resort to other therapy. But yes, where we can remove it. That's right, but
Benign,
I
but it
have seen
may.
really bad patients, you know.
And from our side, invariably there is some amount of extension. It's not possible 100%. And
Yeah,
risky
it's not
also, we may
possible.
pull up the internal carotid, patient may be fatal on the table. And if you are doing, they will do piecemeal. So there may be some
Even they,
amount of, yes,
yes,
they are
you're right.
always doing piecemeal.
But the
technique.
thing is that from our end, we are sending to neurosurgeon
Yes,
because
yes.
that is what best we can do for the patient.
So they can open it up, you can carefully, you can do the surgery and then they can close it.
Yeah,
Yes, yes.
almost always.
Yes, open and closing, their part and the rest.
Because lateral orbitotomy also, it's very difficult to reach that, you know, and grossly leaving the tumor is not.
It is very safe in the apex. If that is any tumor is up to the apex, better you can take a help from neurosurgeon, because they just lift it up the thing. So that all primary vessels are, they can save it. So you can safely you can remove it.
Yes, that's
Then
right.
they can close it. If anything happen, they can go for even the coiling, plaque, everything in the
Yes.
OT.
Okay, thank you so much.
Yes, yes. So if any more questions, so yeah, all are invited. If you have any doubt, any query, we can try as our best. Thyroid also, the ptosis already covered by Raman. Raman, you want to speak something? You want to say something regarding blepharoplasty and something? Yes. Now this technique is a repositioning. You can make a one pocket and you can insert, but it is it take lots of time, of course. Mhm. Yes, yes. Better we can go for direct blepharoplasty also. That is in our population, patients are till now not so much demanding. No, no, in Guwahati also they are demanding like anything. Even in prosthetic eye. Mhm. Even in prosthetic eye, people, that day recently, 3 days back, one lady, young lady, she wants almost, she is downloading 5 videos in front of me. So she is showing, so sir, this is, I want this kind of thing. It is already operated by different surgeons and different surgeons. So it is really, really very difficult in some situations. No, she already did.
Preferably no pain only, but sometimes yes. Where you feel that the it won't hamper much. Neither the well would go off, or the LPS would not improve. You already know what amount he'll be left with. So those type of cases. Any out of any portion of double elevator palsy with this thing, I would have done only less than 5% in the same sitting. 95% is two sitting. You're right, sir. Absolutely.
Two sitting always is better.
Always,
Always better two sitting.
always better.
And then this is sharing technique
Single
we
sitting
can
was
do.
one was from Kashmir patient, coming from very far off. They may not come. A couple of them under general anesthesia because of the chin. So those type of cases where you err towards okay, fine, let's do the same sitting. Otherwise, yes, you're right.
And
95% two sitting.
especially sharing technique you can do in LA also. In double elevator palsy, we are basically doing the sharing technique initially. Sharing technique, there is a no such muscle cut, there is a no such point for anterior segment ischemia or others. So it is little, relatively safer than other screen procedures, though technically is difficult, but in other anterior segment point ischemia complication point of view, and it is little easy, little for patient point of view easier. Of course, surgeon point of view difficult, but we can do in a low LA also. Then second one, if it is more than 16, 15. If it is less than, so no other way. Yeah.
So the vertical fissure height which you are planning to leave after the sling will remain more or less same, which will be directed by the other eye's leg height. Okay. So now once you're doing a hypertropia correction, whether the patient achieves a full hypertropia correction or not, that's a different issue. The vertical fissure height, for example, you have to leave at around 8 or 9 millimeters. So and sling surgeries has overcorrection as a rule. So we will correct it about 9 to 10. So where you do not have a globe for your guidance, you see the fissure width. What I do is fissure height from the lower margin to the upper margin, and that's what guides me. And on table, once you have done the correction, generally you are manipulating the globe. So what I do is I would ask my assistant to hold the globe in the primary position, which is like you have corrected it nicely. It's a like ortho position, and then you would finalize your lid height. So that gives you a guide. If your eye is totally normal, it's in the primary case, and where you are going to leave the tissue. So you move the globe threshold of it of the table. If you are given a block, so the globe would be haywire. Under general anesthesia, you do not know what your correction would come. As you are rightly saying, how do you assess? So you can ask your assistant to bring the globe in the primary position, and then you finalize your height.
But as a rule of thumb, if you want to do, if you are tuned with a adjustable suture, you can do a adjustable suture. This is another option. If no, not sling. If you are doing something, even in sling also next day very easily you can adjust it. Generally, there is a one sleeve is there. You just open up that wound under local anesthesia, just titrate little bit. It can be done.
In these type of cases, what I generally counsel the patient is, anyway you're going to have two surgeries. So we are trying to avoid the second surgery.
Yes.
We're trying to do it in
Next
one
day,
surgery.
next day.
In case you need second, you need second. So you get prepared for two. We are trying it for one, but
in the private practice, always that utter one word, adjust, that is Susar adjustment, not a repeat surgery. It is not a repeat surgery. We are doing the Susar adjustment. That's a very scientific term. No one can say may need Susar adjustment. In that even consent you can write.
I generally write things, there's a bracket, it always says, and there is, you may need a revision surgery.
Revision just or Susar adjustment same. Susar adjustment is a better term.
I don't do adjustable suture.
Yeah. Yes, yes. As you already presume, so better you can. Yes.
That will be on me. I won't charge you anything. So for you, it will be either one go or two goes, and you will have a good result.
That's a very important point. We should not charge that one. Second one on if you there should not be any surgeon's fees. Only if that authority wants, you can go for it on OT charges. No surgeon's fees on the bill. No assistant fees on the bill. Only OT charges. That's no. As no. Raman, it is your hospital. Then you are that thing. You can take the decision.
You charge enough in the first go.
No. He's in hospital. In hospital. If someone is
I am telling everybody, all my colleagues, guys are doing very well. Charge well. Don't underestimate yourself. Charge well. How much? Let's disclose. How much do you charge in your courses? What's the best package? No. Your aims. How much do you charge?
zero. Zero. नहीं भाई कुछ नहीं है जीरो
What do you charge for closing? Good. 45 to 60. Decent.
no you see Raman there is a difference in the per capita income of the state. Yours is a rich state, mine is a poor state. No it is a
I'll tell you one gimmick. You first finish. I'll tell you one
no
very
is
good thing.
it is a
I'm going to give you 10% of your increase in this revenue.
customized. Mine rate is customized. It depends on the if there's a poor community. I know that they cannot afford anything. Girl 18 years marriageable age, I adjust it.
What is your range?
It depends. In 25, and if it is 25 to 25 generally, never more than 25, and if it is poor then it is 18 to 20,
Higher limit is 25.
25 to 30.
Lower limit should be 25.
No,
Even
no.
for the poor family.
No, it's not possible, Raman.
Mine is 25 to 75.
There is difference.
No. I tell you the way you get. That's what I'm going to now tell you. Here, to all of my colleagues, I'm not going to eat up into my practice, but that's what standard is. How do IOL people charge? They say Indian IOL, multifocal, blah blah blah.
See.
Listen. Try to learn if you're not able to do it.
No, I know all.
JK, you have started doing for 2 years, 3 years, 4 years. I've been doing private practice 20 years now. To tell them there are 3 materials. And you have 3 materials in your clinic. You have a reusable material. तो इसमें patient का बचा हुआ है. You can't afford, we'll do it. We ETO, we'll use it. 25,000. Okay. A normal Orolabs.
Good.
35. A multinational material Johnson & Johnson Ethicon. This is 55. When you say I'll use ethical drugs or I'll use generic drugs on you, you will understand. Then let me finish. And most of the people, even which you feel that they are not affording, they will say, "कराना तो हमने best है, उसमें क्या discount दोगे?" Believe me, they will not opt for 25. My 95% clientele is, but they will ask for discount. I'll give them discount. अच्छा ठीक है 55 वाला कर देंगे 50 में कर देंगे नहीं सर और बेटा नहीं तो फिर दूसरा मटेरियल लगाएंगे अच्छा आप इतने में कर देंगे they will settle.
But I'm just telling the truth. In Netralaya is near O. Just I am doing the practice here, 2 kilometers away from the Netralaya. till the phaco IQ charges is 30,800. So mine is generally I am charging 35,000. That ready.
Which I didn't want to tell you, but I'll tell you. I have two, three people who are now doing courses. Earlier, I was the only one. I was the monopoly. I could charge it, right? But of course, depending on what patient could be. Now there are few people doing it. I said they have sometimes the paper in their hand which is written 35. I write 55. And I'll say मैंने देख लिया उन्होंने 35 बोला है और मैं 35 में नहीं करा. मेरा एक्सपीरियंस है 55. अब चलिए आपको सस्ते वाले भी मिलते हैं. आपकी मर्जी है आपने सस्ते वाले से कराना है कि महंगे वाले से. आपने एक्सपीरियंस से कराना है कि आपने
You are in a practice. You are senior. Here you see.
I'm telling you that it's because
Kasturi madam is
he or she is my child. If he or she is my child, I would like somebody experienced to operate on her. ठीक है ना? Nobody wants 10-20 हज़ार से किसी को फर्क नहीं पड़ता. ठीक है? मैं तुमको एक और चीज बड़ी अच्छी समझाता हूँ. मेरे पास एक बंदा आया.
पूरा recorded हो रहा है.
मेरे पास एक बंदा आया. उसकी डॉटर को ऑपरेट होना था. ठीक है?
अभी ऑफ कर दो ये ऑफ कर दो. अभी वन ऑफ कर दो नहीं तो ये फंस जाएगा.